little bit time. So we are going to cover this small for gestational age green top guideline, which has recently been released from the RCOG, and it has got the different the strategies. How are you going to diagnose? How are you going to manage the cases of small for gestational ages? And what is the difference between small for gestational ages and FGR guidelines? The people who are from my group, they already know the half of it, or you can say that the small part of it. So in today's session, we are going to cover end to end that how we are going to diagnose, how we are going to manage, and what is going to be the exam perspective for this particular guideline. All right. So in the end, I'm going to be taking the questions as well. So if anybody has any question, you guys can ask me in the end as well, or even in the middle as well. All right. So no problem. So first, we need to understand that how we are going to, understand the gist of this guideline. All right. So first thing first, I would like to request, please mute yourself, everyone. Okay, because it really creates a lot of chaos in between in the middle of the session. Please, everyone, keep yourself muted at all times until and unless you have any concern, until and unless you have any question to ask. All right. So please don't do that, because otherwise it is going to disturb everyone around. Okay. So we all need to respect each other. We all need to be thinking all the time that we might not be disturbing somebody. All right. Okay. So let's get started. So green top guideline, small for gestational age. And I'm sure many of you guys know me already. I'm Dr.Zaib Qureshi, one of the, the mentor, you can say, for the MRCOG for quite long. Me personally, I'm Pakistani, Karachi based, and I have done MRCOG, HPS, Irish board, as well as the European board as well. Plus, the few others, small, the things too. So not to mention, so I have been teaching for quite long, and I think it's been like, the 8 to 9 years in the online teaching, as well as, the physical teaching. I don't remember since how long I'm teaching. So this way or that way, teaching is my passion. And I'm glad that, I have joined, the webinar to teach and to spread knowledge around as well. All right. So thank you so much, everyone, for joining in. So let's get started. So first of all, first thing first, like I always say, when we are going to keep the concept, so first thing first, we need to understand the definition. Okay. So we have got a couple of definitions here. So the first is appropriate gestational age. Second is small for gestational age. Then we have got fetal growth restriction, and then we have got static growth. Who is going to tell me anything from any of these definitions? What do you understand from STA? What do you understand from FGR? What do you understand from static growth? Anyone? Please, you can open your mic and and just tell me the biggest difference. So let's get started with this background knowledge, and then of course I will explain. Anyone? Mehwish, Salma.
FGR, it could be early FGR, like before it started 32 weeks, or late FGR, it will start after 32 weeks. Early FGR,
what is STA? What is small for gestational age?
If the expected fetal weight is less than 10th centile with abnormal umbilical artery Doppler.
No, this is what I want to tell you is small for gestational age is going to be just small, okay? But when it comes with the Doppler abnormalities, it will convert into FGR, fetal growth
I'm
restriction.
telling you FGR, not FGA.
Okay. All right. Okay. So if you know already, it is good. Okay. So let's have a look on this. First of all, number one terminology is appropriate for gestational age. So when do we say it is appropriate for gestational age? It means fetal size is between the 10th and the 90th centile. So these centiles are the preset on the growth charts. Okay. So anybody who does, the ultrasound, obstetrical ultrasound, or the Doppler ultrasound, the pelvis. So, those candidates must be knowing this, but as an exam candidate, as an OBGY candidate, we should have a vague idea about this as well. Okay. Then the second terminology comes small for gestational age when fetal size only. All right. So first, make a concept on fetal size, and then we will come and talk about the other things. All right. So when fetal size is between 10th to 90th centile, it is appropriate. When are we going to term it as, the small? When fetal size is less than 10 centile. I will show you growth chart as well. So when do you term fetal growth restricted baby? So fetal size or abdominal circumference when it is less than third centile or less than 10 centile with Doppler abnormality. Then, like Dr. Athiya said, that FGR can be early, it can be late as well, right? So if we talk about early, so early is going to be detected before 31 plus 6 weeks or late from 32 weeks, and are characterized by different clinical ultrasound and pathological characteristics. Then FGR is determined by suboptimal fetal growth, has varying definitions. So we are going to be talking in depth as well. So when we say that the growth is static, it means there is no forward growth velocity in estimated fetal weight or AC measured at least, the 14 days apart. Okay, 14 days mean when we do the scan fortnightly and when we don't see any growth, then we are going to label it as static growth. This terminology was not, the present in the previous guideline. Okay, so this is very good that, now they are giving us this, the clear idea, how are we going to at least, the define, and then we are going to manage them. All right. Yes, Saud, which question?
Dr. Zaib, I wanted to ask you,
Mm-hmm.
you know how it says that 31 plus 6 weeks and then 32 plus 0 weeks,
Mm-hmm.
right?
Yeah.
Any significance to this? Why can't they just say that less than 32 weeks is early and more than 32 weeks is?
Very good question, in fact. Okay.
Why do
See,
they always have to say 31 plus 6 and
yes,
then 32
because
plus?
very good question. Okay, I appreciate. Okay, so what happens is that in exam, when you are going to answer, okay, the whole answer will change once, the weeks or days will change. So you have to be very, the kind of specific about these words, as well. When do we say it is 31 plus 6 weeks? So you have to take it up to 31 plus 6 weeks. We all know that in 1 week we have got 7 days, right? So from 32 plus 0 weeks onwards, it is going to be the late FGR. Okay, so because they confuse you in the real exam as well, they are going to give you any particular scenario, and then they are going to be asking you, and then they can confuse you 31 plus 4, 31 plus 5, 28 plus 2. I'm sure you must have seen a couple of questions around. Okay, so the significance is that they really want, because after 31 plus 6, 6 days, after 6 days, 7 days, the seventh day will start, and that will be counted by the end of the day, 32 plus 0 weeks. Okay, so that's why they bring all these kind of the days and terminologies. I have read somewhere in an article that the earlier they used to count hours as well. Okay, so 31 weeks plus 6 days, and then the few hours as well. So somehow the now I think they are keeping all these changes very the evident, I must say, that now we are very clear that how we are going to diagnose, how we are going to label somebody as. Okay, so very good question. Okay, so are we good to go? Are we clear on these terminologies, everyone? Right? So first
Yes.
understand what is appropriate, then small for gestational age, then fetal growth restriction, then group FGR is going to be further divided into two, early FGR and late FGR, and then there is going to be a static growth. All right? Okay. So now let's talk about SGA first, small for gestational age, right? So appropriate, we have just read, okay? So appropriate baby is going to be the one whose size is within a normal range for its gestational age. This is typically defined as between the 10th and the 90th centiles. I will show you growth chart in a minute, okay? So a fetus is considered as small for gestational age when individual biometric, okay? When do we say biometry? What do we understand from this word biometry? Biometry is on the ultrasound in which we are going to see a fetus as a whole, okay? Fetus as a whole body. We are going to check, the certain parameters. We are going to check head with HC, okay? Or we are going to check it with biparietal diameter, BPD, okay? We are going to check abdomen and we are going to check AC, okay? Plus we are going to check the femur length. Plus, we are going to count, all these things, and then we are going to check the estimated fetal weight. All right. So when all these things comes together, then we are going to say that, okay, this is fetal biometry. All right. So in this term, in this guideline, we are going to be talking on two things. So now you are going to make your concepts. Number one, biometry, and then we are going to be talking about Doppler. When we say Doppler, it means now we are talking about the blood flow in the umbilical artery as well as umbilical vein. All right. And then we are going to be talking about that how we are going to diagnose on the basis of Doppler abnormality. And then we are going to term it as FGR. All right. So small for gestational age, when individual biometric measurements or a combination of measurements used to estimate fetal weight fall below set parameters and requires accurate assessment of gestational age. Commonly, the definition of STA refers to a fetus with a predicted weight or an abdominal circumference less than the 10th centile. Very simple, the definition. Okay. So STA is going to be less than 10th centile. But when we say it is severe STA, then it should be less than third centile, even the more the lesser than that. Then SGA at birth is commonly diagnosed based on a birth weight below the 10th centile. Okay. And often birth weight charts are adjusted for the sex of the baby as well, because sex of the baby carries the somewhat different. Male baby carries different characteristics, female baby carries different characteristics. So all these characteristics are preset on the growth charts. Okay. So normally growth charts are given in almost every OBGY department, and the many good hospitals, they do plot on the basis of the ultrasound findings on the growth charts as well. Okay. So when do we say FGR? FGR is the pathological restriction of the genetic growth potential. FGR can also be subdivided into early and the late, depending on the gestational age, with variation in the gestational threshold between 32 and 37 weeks. Okay. Okay. So this is growth chart. Okay. So roughly, I have taken it from Google. So of course, the every unit, every hospital must be having a different one. But we are going to be talking as a whole to make a general concept. Okay. So let's see. Let's suppose these are weeks. Okay, gestational ages. This is estimated fetal weight according to the gestational age. This green line indicates that everything is normal. This indicates that it is the 10th centile. Okay. This indicates it is 90th centile. Okay, a very simple question. If I'm saying something about 10th centile, it means it is SGA. If I am talking something about 90th centile, it means I'm talking about large for gestational age, because it's another pathology, isn't it? Clear everyone, this part? Because this is equally important. And of course, this is another the topic to cover and to discuss. But today we are going to cover this part. All right. So, for example, roughly when we are doing any clinical, the OPD, or you can say the clinic in the hospital, we roughly say that at 30 to 32 weeks, the baby should have a 2 kilogram weight. Agree or no? Right? If everything goes fine, it means that the weight is appropriate. Then at 20 to 22 weeks, the estimated fetal weight is about, the 500 or 550 grams. Very good. The green. At 24 weeks, that's going to be, the little bit above, between 500 to 1000. Then at 28 weeks, it's going to be around 1.5. Okay. Then 30 to 32 weeks, it's going to be 2. So for example, if our parameters are falling below all these things, then we are going to label them as 10th centile. I hope now it is going to make some sense, right? So anything which is going above the preset standard, that's going to be the large for gestational age. Clear everyone? Now I hope the things are going to be easy. Yeah. Clear everyone? This is how we plot things on growth charts. Okay. Mute yourself, everyone, at all times. All right. So I have got 2 yeses, 3. Very good, Amna. Okay. So now you have got an idea about how are you going to plot. All right. On the basis of, the growth charts. All right. So now we are going to, be talking about this less than 10 centile when we are going to be talking about SGA. For example, this dotted area, this is going to be the 10th centile. For example, my baby at 38 weeks has to be up to or equal to 2.923 kilogram. Okay. 2.9 to 3 kilogram, but baby's weight is going even less. This is 10 centile. Okay, it is below 10 centile, then it is going to be labeled as the small for gestational age. Is there any other way to measure? The sonographically they have got the preset all these charts as well, so they can tell us something. Okay, so normally speaking, we plot all these things on the basis of the growth charts, and somehow the many the even government hospital I have seen, and many the private hospitals as well, they do have these growth charts, plus they do plot every the measurement on that. Okay, for example, they do symphysiofundal height. Okay, symphysiofundal height as well, so they do plot symphysiofundal height the on the all these charts as well. And they, if they pick any the discrepancy between the last menstrual period as well as the discrepancy between the symphysiofundal height, then they do plot it on the growth charts, and then they look at clinically that okay, this baby is not going or growing in a proper direction. Okay, normally 2500 is what. This is just a vague idea. I don't know what you are talking about, Jawahir. But the thing is, we need to just fix an idea about what exactly the small for gestational age is. So I think this is going to give you the vague idea. All right. So because there are multiple parameters, so we are going to check that how we are going to diagnose. All right. So then guideline has clearly given us, the few things, the definitions of SGA in current and the previous pregnancies. Okay, so definition of FGR in a previous pregnancy as a risk factor is defined as any of the following. Okay, so now we are talking about, for example, a lady has had the delivery 2 years ago, and the baby's birth weight was below less than third centile in previous pregnancy, or she has had early onset preeclampsia or FGR which necessitated birth before 34 plus 0 weeks in a previous pregnancy, plus or either birth weight below less than 10 centile with evidence of placental dysfunction. All right, so in the previous pregnancy, when we take history, so of course we do they ask all these questions, isn't it? So we do take obstetrical history as well. We do ask that what was the weight of the baby, was it normal, was baby the admitted in NICU, or the was baby was the given to you right away after the delivery. So it will give us an idea. Plus we do ask this question as well, that in which weeks or months the baby was delivered, isn't it? So if you find out any of these parameters, for example, you are going to be thinking of that, okay, that the previous pregnancy was also a risk factor. All right. Then in the current pregnancy, in today's pregnancy, how are you going to define the FGR? Number one, estimated fetal weight, or the AC, abdominal circumference below third centile, estimated fetal weight or AC below the 10th centile with evidence of placental dysfunction, either of them. Yeah. Then abnormal uterine artery Doppler, the pulsatility index above 95th centile, and or abnormal umbilical artery Doppler. We are going to be talking about Doppler as well in a bit. So absent or reverse end diastolic flow or pulsatility index above 95th centile. Okay, so at least for an exam candidate, you need to understand that how are you going to first of all figure it out that in the previous pregnancy, the previous pregnancy was complicated with FGR, or the current pregnancy is also complicated by FGR. All right, then we are going to be talking about what exactly is early FGR, what exactly is late FGR. Yeah, so let's talk about it. So early FGR, if gestational age less than 32 weeks in the absence of congenital anomalies. Okay, so this is a definition. So what do you see in this? AC, or estimated fetal weight less than third centile, or umbilical artery absent and diastolic flow. Stop. Okay, so when we talk about Doppler, okay, so usually what happens is there has to be very smooth flow. I'm sure you all know that in every blood flow, the system, we have got systole, we have got diastole, right? So in systole and diastole, then we have got end diastolic flow as well. If there is, for example, roughly, if we talk about, this is the baseline, this is flow, okay? This is going to be systole, this is going to be diastole, and this is going to be the end diastolic flow. If flow is very smooth, it means that end diastolic flow is present. If this line will touch here, then we will say that the absent end diastolic flow. It means that heart has to pump extra, heart has to pump with the difficulty. It means that the arteries have got some problems, that the blood flow is not going well. Okay, so I'll be showing these slides as well in a bit. So just hang in there. So just first of all try to make a concept. All right, so early FGR, or if they have AC or estimated fetal weight which is less than 10 centile combined with either number one, uterine artery pulsatility index more than 95th centile, or umbilical artery, the pulsatility index more than 95th centile. Okay, stop. Who is going to tell me when do you do uterine artery Doppler and when do you start umbilical artery Doppler? Which one is screening and which one is, the later on monitoring? When do you do uterine artery Doppler and why do you do uterine artery Doppler?
Uterine artery Doppler is done at 20 weeks.
20 weeks.
Just one person, please, one by one. Yes.
Uterine artery Doppler is for screening, basically, in patients having risk factor for fetal growth restriction.
Okay.
And
If there
umbilical is for
moderate or
monitoring.
high risk,
And
moderate risk factors or high risk factors, then we do uterine artery Doppler at around 20 weeks, and then continue it later on at 32 weeks if there is risk factors.
Yes. Okay. So uterine artery Doppler is going to be based on the previous history. So for example, if previous history was complicated by early onset IUGR, or if it was, the complicated by, you can say the preeclampsia or eclampsia, or you can say that abruption, early onset abruption. All right. So in all these scenario, we go for uterine artery Doppler. So what is the pathophysiology of uterine artery? Why do you want to see uterine artery? Why not other artery? Because embryologically what happens is that when vessels are being formed, okay, so with the passage of time what happens is that the fetus is growing, okay, so mother has to pump blood which is going to contain oxygen, which is going to contain nutrients, which is going to contain everything there is, okay. Then there should be a good flow from the mother to the fetus. With the passage of time, in embryologically what happens is that the first, if the vessels were narrow, okay, they were like flaccid, thick, rigid walls, but at 18 to 20 weeks there is going to be second wave of trophoblastic invasion that is going to make these vessels smooth. So what will happen is more contractility, more smooth, the diameter is going to get the wider, so the blood will go smoothly. If there is any problem in the previous pregnancy, early onset, because placental pathologies are 3, okay, so we have got placental pathologies which are 3 only, okay. Number 1, preeclampsia toxemia, second is IUGR, third is abruption. So if any woman has had all these problems in the previous pregnancy, we are going to screen it with the help of uterine artery Doppler in the next pregnancy, just to check if the index pregnancy or current pregnancy is at risk of having IUGR again. Because the major risk factor for all these abnormalities is going to be the, or you can say that one of the risk factor, the previous history of the same condition. Okay, so if uterine artery pulsatility index is more than 95th centile, or umbilical artery pulsatility index is more than 95th centile, okay, now for an exam candidate, you should remember what and memorize what. It should be on your tips, this thing, okay, or because when you will talk about this late FGR, things are going to be changed. In the late FGR, gestational age more than or equal to 32 weeks in the absence of congenital anomalies, okay? So this, in the absence of congenital anomalies, is very important. We are going to be talking about in a bit, okay? So by definition, AC or estimated fetal weight is less than 3rd centile, or at least 2 out of 3 of the following should be present, yeah? From here, we have got 2 things, and we have to have either of them, okay. But in late FGR, because it's a serious pathology now, because baby is growing big, All right. So what is happening? That AC estimated fetal weight is less than 10 centile. AC estimated fetal weight crossing centiles more than 2 quartiles on growth centiles. Or if there is CPR less than 5th centile or umbilical artery pulsatility index more than 95th centile. Okay, all these parameters are Doppler parameters. So 2 out of 3 should be present to label this woman as late FGR. Clear, everyone? So this was, we are moving forward towards FGR now. Okay, so small fetuses are divided into normal. Number one, they are constitutionally small. Okay, constitutionally means their parents are not of that, the big size. So of course, babies are going to be, genetically or constitutionally small fetuses. Okay, non-placental mediated growth restriction means either structural chromosomal abnormality, inborn errors of metabolism and fetal infection, and placental mediated growth restriction, then it will be labeled as placental dysfunction. Or maternal factors such as low pre-pregnancy weight, undernutrition, substance misuse, or severe anemia can affect placental transfer of nutrients as well, right? What are those substances? Smoking, alcohol, cocaine, marijuana, isn't it? So all these things are going to make vessels, the flaccid vessels, the mucosa, or you can say the mesothelium thick. Of course, then the transfer of nutrients, transfer oxygen is going to be less. Then maternal condition, medical conditions that will also affect placental implantation and vasculature and hence transfer. For example, preeclampsia, any autoimmune disease, any thrombophilia, renal disease, diabetes, cardiac diseases, and essential hypertension. Makes sense, isn't it? We do see all these patients on daily basis. Then early onset FGR, we have just said that, okay. Late onset FGR, now the deficit in placentation is milder with less cardiovascular adaptation and a lower risk of adverse event because baby has already been formed. So early onset FGR is going to be dangerous. Why? Because it coexists with the maternal manifestation of the placental dysfunction, which I have just told you, 3 manifestations. Yeah. Hypertensive disorders or spectrum of the pregnancy, including preeclampsia, toxemia, and HELP syndrome. Okay, maternal medical conditions such as, even if it is complicated by diabetes, thyroid, or autoimmune disorders, or autoimmune, the any other thing. So it will also, cause some of the problem in the placenta. Yeah. So early onset FGR will have, the less adaptation by the fetal heart. However, late onset FGR, because baby has already been formed, what happens is that, after the 22 weeks, or even after, when organogenesis has developed, everything has been formed, then later on by 4 or 5 months, baby just has to grow in size and weight. That's it. Okay. So in late onset FGR, the deficit in placentation is milder with less cardiovascular adaptation. Okay. With less cardiovascular adaptation and a lower risk of the adverse event. However, late FGR is more common and it is more difficult to identify fetuses that may be at risk on scan and thus detected, and therefore these pregnancies account for a significant proportion of the adverse outcome. So what happens in all these babies is that, once they are going to be born, either they are going to be having any problem, okay, antepartum problem, intrapartum problem, and sometimes, of course, the grave consequence is going to be the intrapartum death, or, the right before delivery, antepartum death as well. So they are therefore an important area for effective surveillance and management. So who is going to be responsible to detect all these things? You and me, the doctor who is, seeing the patient. Okay. So I think all these guidelines really give us, a fair idea how we are going to, see our patients in our clinic, isn't it? So please, now when are you going to look at your patients? You will definitely, feel the difference in your, what you can say that OPD as well. See, physio-fundal height. Then we say serial. When do you start doing symphysiofundal height measurement in pregnancy? Yesterday, you guys have read antenatal care guideline. My group members, 24 weeks, brilliant. Okay. So when we say serial symphysiofundal height, It means, for example, I have measured my patient at 24 weeks, for example, and it was corresponding to 24 weeks. When I will plot this on my growth chart, so it is going to be fairly good. Okay, because by that, the after that, what I will be doing is that 24 weeks, then for example 26 weeks, then 28 weeks, if there is any this the plotting, then we are going to at least pick any of the fetus who is at having risk of having this FGR. But what happens is it is intervariable. Okay, interchangeable. Everybody has a different the parameters, or different, you can say, the kind of ways to measure. That's why we do take inch tape. Okay, standardized measure. We will keep one part at the symphysis pubis, and then we are going to take it up to height of the fundus. That's why it is termed as symphysio fundal height. Okay, because if we do arbitrary measurement with the help of fingers, because the what you can say, that everybody has difference in the fingers as well, right? So it's a good idea that you measure with the help of inch tape. Okay, and I think this is a the almost a standard protocol in every teaching hospital, that every the trainee should have a inch tape in her pocket. And I remember myself the having all these the gadgets with me all the time in my residency. Okay, I'm sure all of you guys must be having all these things. Yeah. Okay, but what is the the difference for our exam? It has got low sensitivity for detecting SGA and FGR. Okay, SGA and FGR. Oh, Jawahir, inshallah, you will join your residency. Okay, no problem. So now you will have a fair idea that how are you. I'm sure you must have this idea that how do you plot, and how do you measure fundal height, isn't it? So usually the standard protocol is that it should be measured by the inch tape. Okay. Okay, now for our exam, what could be the question? Serial fundal height measurement is a method of surveillance of the fetal size. However, it has a low sensitivity for detecting SGA and the FGR fetuses. Why? Because both are ultrasound diagnosis. However, the serial fundal height measurement can just give us a clue that something is going on. Investigate further, isn't it? Okay. Now then question arises, what are the risk factors for fetal growth disorders in pregnancy? So now we will do the risk stratification. Okay, risk stratification, number one, will start from, like we always say, that history will start from, patient's history will start from age, then presenting complaint, then history of presenting complaint, then in the examination, then investigation, and then comes the management, isn't it? Likewise, in this SGA, if you suspect anybody, so you will do the risk assessment. Risk assessment will start from previous, the pregnancy. Risk assessment will start from previous pregnancy risk factors, then intrapartum, the baby itself, okay, weight of the baby, and then comes the general, the health or the general risk factors of the woman, if she is having any medical disorders or no, her, the habits as well, yeah, smoking, cocaine, addiction, alcohol, or anything, yeah. So you will do the risk assessment. Okay. So risk assessment must always consider previous medical history, obstetrical history, current pregnancy history with information obtained from the woman, review from the medical notes, and contact with the previous healthcare provider as necessary. So how do you assess? Now this is your exam as well. So I really want all of you to focus on this, the part, because this is very important. Okay. So everyone, if you guys are, the in your, the study desk or something, so please keep a register or copy and pen with you and write it down as I am telling you guys. Okay. So this way, the things are going to be easy for you to memorize. Okay. So first thing first, there is going to be low risk woman, moderate risk woman, high risk woman. Okay. You have to do the risk assessment at the time of booking and at the time of mid-trimester anomaly scan. Okay, another concept. Now, first thing first, this is how I memorize. First of all, I will memorize this part, high risk factors, and then, the later on I will recategorize. Okay, so let's cover high risk factors. So which mother is at high risk of development of SGA? For example, now just imagine a patient as a whole. Okay, she is having medical maternal condition, CKD, hypertension, autoimmune disease, SLE, APLA, complex, the cardiac diseases. All right, this is one woman. Then obstetrical history, previous history of FGR, yeah, hypertensive diseases in the previous pregnancy. When we say hypertensive diseases, so make sure that they bring severe preeclampsia, toxemia along with HELP syndrome. Previous SGA, but stillbirth. Previous FGR, okay? Previous SGA with stillbirth, because write it down, because then you have to, differentiate it with moderate risk factor, because previous SGA only is a moderate risk factor, but when it will convert with a stillbirth, it will be labeled as high risk. Okay, so maternal medical conditions, obstetrical history, previous FGR, severe FGR, or you can say hypertensive disorders, previous SGA with the stillbirth, in current pregnancy, what is happening? If PAPA is less than 5th centile, inhibin A in the second trimester is more than 2 multiple of medians, or alpha fetoprotein is more than 2 multiple of medians, or on mid-trimester scan you see echogenic bowel, significant bleeding, estimated fetal weight less than 10 centile, or single umbilical artery. Full stop. All these are high risk factors. So what you will do? Because like we have said earlier, we will do screening. We will start screening with the uterine artery Doppler. Yeah, we will do uterine artery Doppler. Okay, if it is normal, uterine artery Doppler and estimated fetal weight is normal as well. So how are you going to carry the pregnancy, forward? You will do serial scan from 32 weeks every 2 to 4 weeks until delivery. Write it down so you guys will never forget. Okay, so we have got 4 conditions in the high risk, the category. Normal with uterine artery Doppler and estimated fetal weight is also normal. Means everything is normal. So you will have serial scan from 32 weeks every 2 to 4 weeks. Okay, then second category is normal uterine artery Doppler, but weight is less than 10 centile. So you will start, monitoring bit early. Yeah, 26 to 28 weeks until delivery. When we say serial ultrasound, it has to be fortnightly most of the time. Okay, it has to be fortnightly. All right, then the third category is abnormal uterine artery Doppler. See, now abnormalities are kicking in. Abnormal uterine artery Doppler plus, but what is happening? Fetal weight is normal, more than or equal to 10 centile. Okay, so to just highlight this part as well, because you have raised a very valid concern. There are the multiple things in RCOG curriculum. Yeah, more than or equal to, less than or equal to. This also puts all of us at high risk of losing any question as well. Okay, so this is what you have to memorize it clearly and very well as well, because this will also change a complete scenario. Okay, so let me go back to this part. All right. Okay, very good, very good. Okay, so we have got one, the set of women, second set of women, third set of women in which Doppler is abnormal, but baby is normal. Baby's weight is okay, more than or equal to 10 centile. Then the fourth category is in which abnormal uterine artery Doppler and fetal weight is also less than 10 centile. So how are you going to do? See, normal one, you will do, scanning bit later, 32 weeks till 40 weeks. Okay. Then the second, the set of the woman, you will start monitoring little bit early, 26 to 28 weeks until delivery. Then if there is abnormal uterine artery Doppler, so you will start it from 28 weeks every 2 to 4 weeks until delivery. Makes sense? But however, if the uterine artery Doppler is abnormal plus weight is also normal, so this signifies that okay, this baby might not survive. So you will discuss with the fetal medicine specialist. So with my understanding, as per my understanding, so this can come in exam as well. So if you see, any question with this, the set of category, and the option is refer to fetal medicine unit, so you will choose that. All right, clear this part, high risk factor? So if you guys will make notes with me, like how I am, telling you, this is going to be very easy for you in the end to revise from. All right, so high risk category is done. Then comes moderate risk factor. So when we talk about moderate risk factor, so let's see. Then again, previous SGA. Okay, previous SGA means that, this lady has only SGA but not stillbirth. Once it will be added with stillbirth, it will convert into high risk factor. Okay, previous history of stillbirth only. Okay, mind it. This is not SGA with stillbirth. Okay, this is only previous history of stillbirth due to any reason whatsoever. Or if it was appropriate gestational age, but no, the birth weight, appropriate gestational age, birth weight. In the current pregnancy, if she is a smoker, if anybody remembers from previous SGA guideline, so they used to have that, 6 to 11 cigarettes was moderate, more than 11 cigarettes was high risk factor. But now, the smoker of any number of cigarettes, it is moderate risk factor. Okay. So be extremely careful when you solve all these questions from the old patterned, the books or anything. All right. So make sure that you are not choosing on the basis of, the old guideline, because in the old guideline, 6 to 11 cigarettes were moderate and more than 11 cigarettes were high risk factors. This is the biggest change in this guideline. Then drug misuse, women of more than or equal to 40 years of the age at the time of booking, or if the BMI was at extremes, BMI was less than 18.5. This is also, the change. In the old guideline, BMI of extremes were in the moderate risk factor. Okay. Now they have just taken, the BMI of less than 18.5. I'm sure you all know that what normal BMI is, what is, the obese and what is morbidly obese, blah, 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 right? Underweight and all. So 19 to 24.5 is normal BMI. Okay. So less than 19 will be considered as BMI underweight. Okay. So now BMI less than 18.5. Okay, BMI less than 18.5 and other features like eating disorders, if she has any bulimia nervosa, anorexia nervosa, okay, so that will also be including in this. Bowel disorder causing weight loss, or if she has had any gastric bypass surgery, previous history of preterm birth, second trimester miscarriage. But if it was placental mediated means what we have talked about, the placental disorders, isn't it? Early onset FGR, early onset abruption, early onset, the hypertensive disorders. So in all these things, what you will do, you will assess for the history of placental dysfunction and consider prescribing aspirin. All women on the moderate risk pathway require one of symphysiofundal height measurement at 28 weeks. Okay, so symphysiofundal height measurement is going to give you a clue that, okay, this lady can be at risk of development of FGR. Then what you will do, this was at the time of booking. Then you will do anomaly scan at 20 to 22 weeks, and then you will look at the normal parameters and everything. If anomaly scan was done and estimated fetal weight is more than 10 centile, it means it is a normal, somewhat normal thing. In this scenario, you will just do serial scan from 32 weeks, but every 4 weeks. In the high risk category, you were doing fortnightly. Okay, but it was also 32 weeks. However, in this set of women, you will do every 4 weeks, means every month. Right? So for this, for high risk category, in this, because we are talking about placental pathology, we are talking about resistance. So what you need to decrease the resistance? Resistance is because of the thickness of the viscosity of the blood. So you need to decrease the viscosity of the blood. You have to give aspirin, high dose aspirin of 150 milligram at night, less than 16 weeks as appropriate. For example, to the women who have had previous hypertensive disorders, previous FGR less than 3rd or 10th centile, and the babies were born less than 34 weeks as well. So this aspirin is going to give the good result in this set of women. All right, clear everyone? High risk factor and moderate risk factor. At least make a concept now, and later on, once you will revise it with yourself, I think then it's going to be very easy to understand. Okay, if the woman was categorized low risk because she was not having any risk factor, okay, so in this scenario, what you will do, you will just have an anomaly scan, and estimated fetal weight was also normal. You will just do serial measurement of symphysiofundal height. Okay, so I think now all these questions comes in exam, that with no risk factor, what you will do serial measurement. With moderate risk factor, you will do serial scan from 32 weeks, but monthly. Okay, high risk category is pretty, different. Okay, then two mild and moderate. Mild means no risk factor, mild one. You will reassess every woman at 28 weeks and after any antenatal admission. This is pretty, the different from the previous guideline. Okay, admission was not there, but now they have given this antenatal admission as well. You will reassess at 28 weeks because anything can happen later on, isn't it? After anomaly scan, anything can happen, because the standard protocol for the scans in pregnancy is only two in the low risk category: just dating scan and then anomaly scan. That's it. Okay, so if on symphysiofundal height, you see any kind of problem, so you will assess for any complication developing in pregnancy, for example, either hypertensive or if there was significant bleeding. Okay, so in this scenario, you are going to be having serial scan from diagnosis until delivery. Okay, serial scan from diagnosis until delivery, and then every woman will be labeled individually. Then the last set of category, like I have said earlier, previously in the previous guideline, extremes of weight were in the moderate or the high risk category, but now underweight is in the moderate risk. However, women who are unsuitable for monitoring of the growth by symphysiofundal height measurement, for example, if their BMI is more than 35 kilogram, or if the pregnancy is complicated with fibroid or any congenital uterine anomaly, or even ovarian cyst as well, in which we cannot predict that, okay, this woman can be at risk of development of SGA. All right. So in these set of women, you will have anomaly scan and you will look for estimated fetal weight. If it is more than 10 centile, good. So what you will do serial scan from 28 weeks in the woman with congenital uterine anomalies, and 32 weeks in the woman who are unsuitable for symphysiofundal height every 4 weeks until delivery. Okay, so having said that, if we say that the woman is unsuitable for symphysiofundal height, so you can fairly think of this thing: if a pregnancy is with fibroid, if a pregnancy is with any ovarian cyst, or the any other thing, so yeah, symphysiofundal height is going to be quite tricky. Okay, you cannot measure properly. Clear everyone? This chart should be on your tips, guys. Okay, so I would recommend all of you guys that either you make your own notes, or either you get it printed, paste it in your on your study table, in the study room, anywhere. So revise it on daily basis, because of course these changes are pretty new, and of course it will take some time to fix in your minds as well. Brilliant, Amna, brilliant. Clear everyone? Any question? Any question? Yeah, Saud, very good. Brilliant. Okay, so let's move forward. Okay, all right. So now we have just read about, thank you, Mavish. I was waiting for your message. Thank you so much. Okay, all right. So we have said that we are going to, to look for everything. So we will start. So now another concept. we have got almost 11 risk factors to stratify. Okay. Now, what are the 11 risk factors? Booking history. A woman will be booked, when a woman is coming at the booking visit, you are going to have the complete history. You are going to stratify who require increased surveillance, okay, the birth weight, gestation, and the birth weight centiles of all previous, the proposed plan of assessment. You will ascertain the previous history of the FGR or STA. You will ascertain the previous history of stillbirth, okay, previous preterm birth history as well. When we say previous preterm birth, it is very much important. Yeah, preterm birth at what gestational age? That is important, because this will give us a clue in the index pregnancy that, okay, this pregnancy can be complicated by the early onset FGR or late onset FGR. Okay, so if previous preterm birth before 37 weeks have an increased risk of SGA or FGR, this effect is greater after extreme preterm birth, which was 22, 27 plus 6 weeks. Means as we will go back in the gestational ages, the chances of having complications in the index or the current pregnancy will be high. Okay. Then it is recommended in any woman with a history of preterm birth or a second trimester pregnancy loss that a detailed history is undertaken to determine whether the placental dysfunction was implicated. Stop here. Why? We have got a couple of the types of preterm birth as well, isn't it? Number one is the spontaneous preterm birth. Second could be the indicated preterm birth. Indicated preterm birth, for example, if a lady has developed severe preeclampsia by 28 weeks, okay, which is not controlled by the 3 or more drugs, then what we need to do? We have to deliver the baby, because the pathology is where? In the placenta. Right? So if the preterm birth was because of the placental dysfunction, that is another risk factor. Okay, so in this, the type of preterm birth which was associated with placental dysfunction, so this lady requires ultrasound surveillance and then aspirin as well. Okay, so previous history of pregnancy losses. So which pregnancy loss? We are much more concerned with the second trimester loss. Previous pregnancy, if it was associated with any placental mediated complication, right? Again, the same FGR, abruption, hypertensive disorders. So in this scenario, what you will do, you will start 75 to 150 milligram aspirin from 12 plus 0 weeks onwards until the birth of baby. Stop here. Okay. There is no rule that you are going to stop it at 36 weeks. Okay. This is done by the old school of thoughts. Okay, so there are plenty of books which are not revised for years and years, but they do have the quality questions. So when do you solve questions? So make sure that you are bringing keys according to the new guidelines. All right, so this is until the birth of the baby to reduce the risk of hypertensive disorders related to placental dysfunction, particularly preeclampsia. Then the second set of the women is in women with previous FGR, including those born preterm. Clinicians should determine whether placental dysfunction may have been a contributory factor. Then you may advise a low dose aspirin, 150 milligram from 12 weeks of gestation. Aspirin may be more effective if taken at night. New thing, yeah? In some circumstances, it may not be appropriate, and the lower doses, 60 to 75 milligram, may be used, for example, a woman who is having hepatic or the renal disease. Okay, hepatic or renal diseases, you need to give the lower doses. Otherwise, standard dose is the 150 milligram. This is also revised from the previous guideline. Clear everyone this part? Because this is clinically important as well. Many of us are clinicians, so I think this will help you in your clinics as well. Then comes maternal characteristics and the medical history. For example, if she has had SLE, if she has had the congenital heart disease, and if she has had any the anemia, asthma, inflammatory bowel disease, depression, they are less strong. However, SLE, APLA, okay, they are having the strong association. Advanced maternal age of 40 and more is associated with an increased risk of SGA and FGR. Bariatric surgery also, because what it will do, it will cause nutritional deficiency, right? Then ethnicity specifically Southeast Asian, African, Black African, Caribbean, have been reported to be associated with an increased risk. Nulliparity, social deprivation, unmarried status, maternal SGA, a short less than 6 months or a long over 60-month inter-pregnancy interval, they have minor association. Okay, although they do. So that's why the complete risk stratification is pretty much essential to diagnose any woman at having risk of SGR. Congenital uterine anomalies, they are also risk factor for FGR. Then these women are at high risk of adverse, the outcomes as well. So what are the adverse pregnancy outcome? Preterm birth. Antenatal risk factor. For example, several maternal exposures have a seemingly causative relationship with the fetal growth disorder. For example, nulliparity, social deprivation, unmarried status, maternal SGA, a short, the inter or a long interpregnancy interval. All right. So this is going to, pose multiple problems as well. Yeah. So it is important that, when we talk about all these, the women, so you do take complete history, detailed history as well. Yeah. Okay. Then drug misuse, specifically cocaine use. What does cocaine cause? Which pathology? Placental pathology. Abruption. Okay. Real exam scenario in part 2 as well as part 3. Okay. Cocaine is associated with placental abruption most of the time. Maternal caffeine consumption of 300 milligram per day or more in third trimester has been associated with SGA, with evidence suggesting that even lower consumption has an association with SGA. A systematic review, IVF, ICSI, maybe. Extreme paternal ages as well, below 20 and above 40 years, height and paternal birth weight, and no association with SGA. Okay. In the previous guideline, it has been shown that the paternal SGA also is a minor risk factor, but now they have withdrawn this risk factor as well. Okay, so changing paternity has been associated with an increased risk of SGA infant and preeclampsia, even after taking into account. Please mute yourself, everyone. Okay, mute yourself. Screen is there, sweetheart. I think you need to join again. Let me share it again. Ruxar, please mute yourself. This is really causing a lot of trouble. Okay. In the current pregnancy again. Okay. In the current pregnancy, you will be looking at biochemical markers used for aneuploidy screening. And we all know that what are the biochemical markers? TAP-A, alpha-fetoprotein, inhibin A, all right, HCG level. So if all of them are, the more than 2 multiple of medians, so yes, the chances of, the SGR is going to be there. Then in the mid-trimester scan, what do you see in the mid-trimester, right? In the mid-trimester anomaly scan, you will be checking the uterine artery Doppler, yes? At the same time, you will be checking the anomalies in the baby. So you will be looking at aquagenic bowel, single umbilical artery, and fetal biometry if the birth weight is less than 10 centile. So you will be picking up the, risk factors again. Then risk factors developing in the pregnancy. Women should be reassessed for their risk of the GR throughout pregnancy and after any antenatal admission. Risk assessment should be a continuous process. A 28 weeks appointment presents a universal opportunity to review the pregnancy. 28 weeks appointment is very necessary. Okay. Antenatal admissions will be promoted by the changes in the maternal or the fetal condition, and thus should prompt a reassessment of the FGR plan. Women with hypertensive disorders need to be reassessed. Women who have seriously or been critically unwell, for example, because of the any virus. Recently, we have been suffering from COVID-19. Okay, so COVID-19 should be offered a scan to assess the fetal biometry. It seems reasonable to arrange the first scan within the first 14 days following recovery and to consider further ultrasound monitoring on an individual basis. New thing, keep it in your mind. For women who have been acutely unwell with COVID-19 and there is a risk factor that the severity of the illness may affect fetal growth, So all these women should be, the checked as well. Okay, clear everyone? So almost 11 risk factors are there which you need to be thinking at all times when you are going to be looking at the patient. Clear everyone? Hmm? At least I need, few yeses, okay, to move further. Otherwise, we will be stuck here. Very good. Very good. All right. All right. Brilliant. Okay. So now you have to stratify between the SGA and the FGR. So you will be using prediction models. Okay. They are preset, the performers, or you can say, the whatsoever things. So prediction models should not be used as the only method, number one. Okay. So multi-parameter competing risk models for the preeclampsia and placental dysfunction can be used to help reduce the risk factors of preterm SGA. Preeclampsia prediction model can identify a high proportion of the cases. Implementation of these models require, the local resources, training, quality control as well. So that's why they cannot be used as a sole parameter to identify anything. Yes, they can be a helping tool, like the growth charts and everything, and the risk stratification of the FTR and the SGA can be done. Okay, now question arises, how can the risk of FGR in pregnancy be reduced? Important, isn't it? So what you will advise to the woman? Number one, reduce smoking in the pregnancy. Okay, because smoking increases the risk of SGA, and the woman who can stop, the smoking can reduce their risk of the SGA as well. All women continue to take 10 microgram per day of vitamin D and 400 microgram per day of the folic acid. Both should be from preconception 3 months and for the first 3 months of the pregnancy as well. The benefit is that they will reduce the chances of having preeclampsia, SGA, and FGR. Although it is uncertain, but yes, the studies are going on that it can be helpful. Then supplementation of the omega-3 long chain polyunsaturated fatty acid has not been shown to reduce the SGA and the IUGR. High dose folic acid has been previously suggested to reduce the risk of SGA, but the fact study was a long study done on all these women. They said that it's a good idea that you just do the standard preconception dose, which is 400 micrograms per day. Okay. Then calcium supplementation has been suggested to reduce the incidence of preeclampsia, although a Cochrane review reported a modest, almost 8% reduction. I mean, even if it is 1%, it is good. The benefit of vitamin D supplementation to reduce the risk of preeclampsia, SGA, and FGR remains uncertain. However, several systematic reviews have not found evidence of the reduced preeclampsia or stillbirth, but some evidence to reduce the risk of low birth weight and SGA as well. So I think it's a good thing as well. So what are the strategies? Stop smoking, give them vitamin D, give them folic acid standard dose, okay? Give them calcium supplementation. Calcium supplementation will reduce the chances of having low birth weight as well as FGR and SGA. Okay, and there is uncertain role with the omega-3 long chain polyunsaturated fatty acids, and there is insufficient evidence that the high dose folic acid is going to reduce. Clear this thing, because now things are easy, isn't it? Okay, then a woman who is at risk of development of fetal growth disorders. So in this woman who is taking folic acid and vitamin D doses above the recommended dose doesn't appear to provide any additional benefit. But a woman at risk of preeclampsia and or placental dysfunction, they should take aspirin 150 milligram once daily at night from 12 weeks to 36 plus 6 weeks of pregnancy. So it means we are going to the term, okay, till delivery. 37 is the term. To reduce the chances of having SGA and FGR. There is good evidence of aspirin safety and efficacy at 150 milligram, and doses below 100 milligrams should be given to the hepatic and the renal, the patients. Low molecular weight heparin should not be prescribed to reduce the risk of SGA or FGR in at-risk women. Okay. So what are the strategies again? So maternal micronutrients, okay? Maternal micronutrients, for example, magnesium, selenium, ABCD, you know, the anything. Yes? Yes?
First, we have read that we should start aspirin from 12 weeks until delivery, and here it is written up to 36 plus 6 weeks.
So 36 plus 6 weeks is term, right?
First, we read.
It is term.
Yes.
36 plus 6 days means that any time if a woman delivers, it is normal, right? Clear?
Yes.
Okay. Brilliant. All right. Now, then surveillance. Surveillance is very important, right? Surveillance is going to be according to their risk stratification, number one, okay? If it is low risk, so we will just do we will do what in the low risk category? Anyone? Be quick. What do we do in the low risk? Some fundal height measurement, right? And then we will reassess them. We will reassess them at
admission or 28 weeks.
28 weeks. Brilliant. Okay. Then the low risk of FGR, we will do clinical examination, fundal height measurement, serial fundal height measurement. Okay. We will plot them on growth chart. All right. And, but again, you know, there is going to be problem if a woman is having, you know, the BMI more than 35 kilogram or having large fibroids or polyhydramnios, isn't it? So because fundal height has got low sensitivity to detect FGR. Then we will do, you know, the second thing is universal ultrasound. Universal ultrasound means we will do the anomaly scan. We will look for fetal AC and estimated fetal weight in the third trimester. Okay. And we will be plotting them again. All right. Then a woman who was on moderate risk of FGR, we will do ultrasound biometry. And ultrasound biometry, we have just mentioned before that it is going to be estimated fetal weight, it is going to be HC, it is going to be, you know, the AC. Okay, three things. Now, what is happening? Women in the moderate risk factor category are at risk of late onset FGR. Okay, so please, I think this can be a question as well, and so require serial assessment of the fetal growth commencing at the 32 weeks. For the majority of the women, a scan interval of 4 weeks is appropriate. If two estimated fetal weight are to be used to estimate velocity, they should ideally be a minimum of 3 to 4 weeks apart to minimize the false positive rate for diagnosing FGR. So that's why we are you know, looking at least 2 to 4 weeks difference. Assessment of the fetal AC may help in determining the fetus that is FGR, because through fetal AC we do try to take the estimated fetal weight. AC and AC growth velocity can help determine those at risk of having neonatal morbidity when assessing fetal size with the head-log formula. Okay, HC, AC, and FL. Changing estimated fetal weight formula during growth monitoring can lead to an, you know, the artifactual change in the growth trajectory and should be avoided where possible. So this is an equal responsibility of the sonologist who is, you know, the taking. So that's why it is very mandatory that we should be doing all scans from, you know, the one place. If you can do it yourself, well and well good. If not, then choose a laboratory or choose a sonologist who is pretty good in doing all these scans. Okay, so there should not be, you know, the different scans from the different, you know, the laboratory or the sonologist, because it can give us many, you know, the problems later on. So maternity providers should ensure that they clearly identify the references charts to plot the individual biometry assessment and everything. Makes sense, right? When determining which charts are to be used, following should be considered. Fetal growth charts must be based on sonographic estimated fetal weight, not newborn birth weight standard. Fetal growth charts should be developed using methodology that is of the lowest bias with the population level data, ideally obtained prospectively and related to the prescriptive fetal growth. Then universal references charts. So all these charts are, the preset standards in almost, the every maternity unit or the hospitals. So all these, the very important. Then if we find out any problem on the symphysiofundal height and the growth charts, okay, we will refer the woman to the fetal medicine unit in the severe category, right? So a diagnosis of growth disorder, a decision about management based on fetal well-being should be informed by the high quality measurements and reports. This require appropriate training time, of course. So it means we need to have good, the sonologist as well. Okay. Then the risk factor, what we have done earlier, those routinely assessed at booking and the mid-trimester scan, other risk factors exist and the risk assessment must always be individualized. Okay, so we will be looking at everything. We will be doing serial measurement of the symphysiofundal height, should be performed as per NICE guideline. AC or estimated fetal weight less than 10 centile at the anomaly scan is a high risk factor. Okay, so that's why anomaly scan should be done by a experienced sonologist, and it should be written that why I would like to see anomaly scan along with AC and estimated fetal weight, because if the lady is having at high risk of FGR, so this will give us a clue. Okay, so I think this could be our question as well in the exam. Then an individualized plan of the care should be made, refer to the risk assessment and screening section, and then we are going to monitor. What about drugs and the association with the IUGR? Okay, so aspirin, if we, the initiate, so we can prevent preeclampsia, is the most effective when we are going to be starting from 12 weeks onwards. NICE guideline says that, we have to start it until birth of the prevention of hypertensive birth. But other guideline says stopping at 36 weeks, because we are in RCOG curriculum. So we will be following NICE, okay, until birth. This is what I was emphasizing on earlier. So aspirin may be associated with an increased risk of postpartum hemorrhage, and thus the suggestion that it should be stopped at 36 weeks or even at the end of the second trimester. It may be associated, so it is suggested, but it is not proposed yet. However, it is not clear. Okay. Thus, in the context of this guideline, aspirin should be ideally commenced at 12 to 16 weeks until at least 36 weeks, but preferably until delivery. Okay. See, this is just the game of, the wordings. Okay. Until at least 36 weeks means every woman should be taking this at least 36 weeks, but preferably until delivery. And no use of low molecular weight heparin, okay? And antihypertensive drugs does not seem to increase the risk of SGA itself. However, the beta blockers, if we are using in the hypertensive, but, the data is still inconclusive, okay? Then comes, the management. How do you manage such women? Okay, this is important. So management is important in terms of that ultrasound biometry should be carried out every 2 weeks. Then umbilical artery is the surveillance tool. In fetuses whose birth weight is, no risk of APH. Okay, no risk of APH, no risk of PPH. The dose is very less. 150 milligram is nothing. Okay. Estimated fetal weight between 3rd and 10th centile. Other features must be present for the birth to be recommended prior to 39 weeks. Ideally, every SGA baby should be delivered by 39 plus 6 weeks. Okay, means which is again 40 weeks. So what do we say the term? Term is from 37 to 42 weeks, but at least by 40 weeks. For women who are recommended for induction or planned birth after 39 weeks of SGA, but who wish to continue the pregnancy, counseling but includes the discussion regarding evidence that there is no additional risk factors to the baby or for the woman from planned birth or induction at this gestation when compared with the expectant care. So an individual plan of the care should be made. After 37 weeks, abnormal middle cerebral artery or cerebroplacental ratio or umbilico-cerebral ratio, UCR, can be used to guide timing of the birth. This is pretty new because previously we were just using what? To time birth. ductus venosus Doppler. Okay, but now we are using, ductus venosus Doppler was for preterm delivery. After 37 weeks, now they are saying that we are going to be using the middle cerebral artery Doppler, cerebroplacental ratio, or umbilicocerebral ratio. New thing, isn't it? So please, keep this thing in your mind as well. So abnormal MCA, CPR, or UCR does not provide reassurance that the fetus is not compromised, and in all cases, birth is recommended by 39 plus 6 weeks, not beyond that. Induction is not contraindicated in STA fetus, full stop. Okay, compared with the non-STA babies, STA fetuses are at high risk of developing fetal heart rate abnormalities and thus unplanned cesarean birth. So what do we need to do is that once STA mother or baby is in the labor, we will do electronic, the fetal monitoring, continuous CTG, and then we will be looking at, any fetal heart rate abnormality. Induction between 37 and 38 weeks must only be considered as an intervention for the fetuses at significantly increased risk of perinatal mortality. For all fetuses with an estimated fetal weight or AC less than 10 centile, where FGR has been excluded. Okay, this we are talking about only STA excluded minus FGR. Birth or the initiation of induction should be considered at 39 weeks. It means, now let me conclude, for any STA baby without any problem, birth should be by 39 weeks and FGR should be individualized, be it early or late. So it will be individualized. Okay? Clear, everyone? Everybody has gone so quiet. Clear, everyone? I hope it is not boring. Mm-hmm. Good. All right. Great. Okay, so FGR fetuses, we have just said, the early and late. So the biometry is going to be every 2 weeks. Okay, and Doppler is going to be accordingly. Okay, so from 26, birth should be based on the fetal well-being assessment or the maternal indication as well, as follows. How? The less than 26 weeks, very dangerous area. Okay, it needs to be personalized. Okay, it needs to be personalized, less than 26 weeks. Every pregnancy should be individualized by less than 26 weeks. Okay. At least 36 weeks, preferably until delivery. These are the words for part 2. Okay. You're not going to stop. Guideline has clearly mentioned that there is no clear data that it will be complicated by the bleeding. So at least every woman should take it by till 36 weeks, but preferably until delivery. Okay, from 26 weeks, birth, if any of the following is present: spontaneous, repeated, persistent, unprovoked fetal heart rate decelerations, 26 to 28 plus 6 weeks. Birth, if ductus venosus A wave is at or below baseline or STV is below 2.6 milliseconds. For an exam candidate, don't put a lot of stress on this. Just keep a concept, because all this is the Doppler language. Okay? From 29 to 31 plus 6 weeks. So just keep it in your mind that ductus venosus will be used for to time the preterm delivery. Okay, in the FGR, right? And later on, the ratios, cerebroplacental, cerebrovascular, those ratios will be for after 37 weeks. Another concept. Okay. 29 to 31 plus 6 weeks. Birth, if ductus venosus is at or below baseline or STV is below 3 milliseconds. 32 to 33 plus 6 weeks, consider after 30 weeks. If birth, if umbilical artery and diastolic flow is reversed. From 34 weeks onwards, consider after 32 plus weeks if umbilical artery and diastolic flow is absent. Absent, reverse, and see, this is preterm. So we are taking ductus venosus. Clear this part? If anybody who is in, the something or somewhat of radiology sonography, so you guys will understand. So just for the understanding, I just took, all these from, certain radiology books. So umbilical artery Doppler. So we will quickly go through that. How do we, they look at the Doppler. So umbilical artery Doppler, it gives us, the information, and because of the placental vascular resistance. This is measured RI, which is resistance index, which is calculated as PSV, peak systolic velocity minus diastolic velocity divided by peak systolic velocity. Systolic to diastolic ratio, ST ratio. This is important. Then we talk about multiple times peak systolic velocity. So whichever ratio is used, the overall hemodynamic changes assess the increase in the resistance within the umbilical artery. As a normal pregnancy progresses to the second and third trimester, the resistance should be less. Okay. With the advancing gestation, then the placenta will be, the big. It means the resistance should be decreased. If placental resistance is increasing, it means there is going to be problem. Normal physiology is placental resistance should decrease towards term. But if placental resistance is increasing towards term, it means it is causing problem. The velocity is represented by a scale of the arbitrary color ranging from minus means moving away from the transducers, to the 0 or no calculated velocity, or to the plus moving towards the transducer. The pulse frame rate affects the real-time color Doppler measurement. So it is very much important that what we are doing. So normal ratios and the resistance are there, okay? Because like I have said, that in the first half, resistance is going to be, the flow is going to be more, okay? In the second trimester or the first half of the pregnancy, the umbilical artery will demonstrate minimal end diastolic flow due to the high peripheral resistance in the placenta. At this age, the placenta is composed of few vessels, but vessels will increase in the pregnancy because it will progress into the third trimester. So the ST ratio most of the time is normal between 3.3 to 4.3 and will decrease to between 1.7 to 2.4 in the third trimester. Initially, it will be, so normally we do take ST ratio as, it has to be less than, the 1, 2, 3. It has to be like this, less than 3, less than 2 in the first, second, and third trimester. Okay, so because if ST ratio is less, it means flow is good with the advancing gestation. So normal umbilical artery flow mirrors uterine artery flow and shows progressive increase in the diastolic flow after 18 weeks, leading to a decreased ST ratio over the course of pregnancy. Systolic versus diastolic ratio. It means flow is good, heart is pumping good, and the flow is equally distributed. So ST ratio is normally less than 3.5 in preterm fetuses and less than 2.5 at term. In normal pregnancy, there is progressive increase in the end diastolic velocity due to the growth and dilatation of the umbilical circulation. The RI, resistance index, therefore falls. Means with the advancing gestation, like I said, that placental size is more, resistance should be less. So resistance index, if it is more than 0.72, is outside the normal limits from 26 weeks of the gestation onwards. So this is the normal, the Doppler picture. See, these are, the parameters, okay? This is the velocity in the centimeter per second. So this is how, because the machines are preset, okay? So just for the understanding, they will keep the probe, the hair on the fetus, umbilical artery, all right? And then they will look for the flow in the vein and the artery, right? So how do they check? They are going to be plotted on, like this. Ideally, this is systole, all right? This is diastole. This is normal flow and diastolic flow. What is this? Which picture is this? Anyone? Can you guys comment? What does it show? Just this graph. I have just
reverse and diastolic flow.
How reverse? I have just shown you this is end diastolic. Okay, this is end diastolic. So flow is good. So what is this? There is no end diastolic flow. Okay, absent. This is what? This is normal, right? This is what? This is what?
Reduced end.
Hmm? This is again absent, right?
Absent flow.
This is absent, right? This is absent end diastolic flow. This is reverse. When it will go below that, the threshold, this is reverse end diastolic flow. Okay. So even if you don't know anything from, any of the, the Doppler thing, if we generally look at all these pictures, we can just have a vague idea. I hope you will get an idea after this session that how to just simply interpret, even if you don't know all these the physics and all. Even you just look at this picture, you can simply get an idea. This is reverse, this is absent, this is normal, this is absent, this is normal. Good one, right? Clear everyone now? Okay, so late FGR, we have said that, the in late and term FGR, assessing the ductus venosus is unlikely to be informative. So that's why ductus venosus will be assessed as a surveillance tool in the early onset FGR only. In the late FGR, what you will use, you will use umbilical artery, the parameters, right? So then,
Middle cerebral.
yeah, middle cerebral artery later on, and ratios. Okay, cerebrovascular and cerebroplacental. For fetal assessment, birth should occur if any of the following are present: spontaneous, repeated, persistent, unprovoked decel, or if contraction CTGs, the STV analysis is 3.5 millisecond at 32 to 33 plus 6 weeks, or less than 4.5 milliseconds at 34 weeks or above. This, of course, will come if you guys have seen any contraction CTG, okay? Contraction CTG in which, we give stress through the oxytocin, and then we check how baby is coping with the contractions. So that will be, so all these, the findings will be noted on the CTG machine. Or if a patient is having abnormal umbilical artery Doppler as follows: if absent end diastolic flow, we will consider at 32 weeks, or absolute by 32 weeks. See, consider means we will do plus minus, but definitely we will deliver by 34 weeks. Or if there is any raised umbilical artery pulsatility index, we have just mentioned before that resistance should decrease towards the term. If resistance is increasing and if the resistance is above 95th centile, okay, so it is then we will sorry, pulsatility index, not resistance, okay, pulsatility index, PI, then we will manage 36 to 36 plus 6 weeks. So in pregnancy which are complicated by FGR, birth should be initiated between 37 and to be completed by 37 plus 6 weeks. Okay, stop here. This means that we are talking about late onset, the FGR. So in this, we will do the cerebral Doppler, MCA, CPR, UCR, right? So it can inform monitoring strategy and frequency, but should not be used to determine the birth decision prior to 37 weeks. Prior to 37 weeks will be ductus venosus. In late FGR or a woman's subjective assessment of reduced fetal movement or absent movement on ultrasound should prompt an assessment with the contraction CTG, CCTG. Okay, it is important. So consensus management of the late preterm FGR suggests birth if the umbilical artery end diastolic flow is reverse at 32 weeks, absent at 34 weeks, and raised pulsatility index at 36 weeks. Late preterm FGR means which are developing from 32 to 37. So you can see that anyhow they are delivering baby by 37 plus 6 weeks. For all babies with FGR, birth should be planned for or initiated by 37 weeks and should complete it by 37 plus 6 weeks. plus minus, you can simply, think of 38 weeks, 37 to 38 weeks. Okay, clear everyone? Now we will discuss about the Doppler. Okay, the role of Doppler and the role of the monitoring in the FGR setting. All right, so early FGR up to 32 weeks and late FGR, right? So how do you monitor early FGR? You will do estimated fetal weight, means you will do biometry fortnightly. Write it down so you will never forget. Biometry fortnightly and Doppler weekly. Okay, and then you will do the management according to the gestational age, 24 to 25 plus 6 weeks. If there is absent end diastolic flow or reduced end diastolic flow in umbilical artery, you will monitor minimum twice weekly with CCTG and or ductus venosus, because we are talking about early onset. This set of women, 24 to 25 plus 6 weeks, extreme preterm birth. So we will do individualized care. Then 26 to 28 plus 6 weeks, we will deliver them if ductus venosus artery is absent or STV is less than 2.6 milliseconds. Then the third set of women is 29 to 31 plus 6 weeks. We will deliver if it is absent or STV analysis is less than 3 milliseconds. All right, clear this part? We have done Doppler. And if there is any absent or reduced end diastolic flow, we will monitor them twice weekly. Otherwise it is weekly. Clear? Along with, we will do CCTG and ductus venosus Doppler, because we don't know, anytime we need to time the delivery in the preterm birth. All right. Then there is late FGR. In late FGR, we will do biometry fortnightly, but Doppler weekly. Okay, fortnightly, almost same. Okay, estimated fetal weight means biometry fortnightly and Doppler weekly. Okay, now we will categorize women into two sets. One set of women is 32 to 33 plus 6 weeks. So anytime in Doppler, if we see absent or reverse, we will do twice weekly monitoring and along with CCTG and ductus venosus Doppler. And we may plan to deliver if ductus venosus A wave is absent or STV is less than 3.5. See, 2.6, less than 3, less than 3.5. Easy to memorize. However, the last set of women, 34 to 36 plus 6 weeks, umbilical artery Doppler, if pulsatility index is more than 95th centile, we will monitor again twice weekly, only CTG, because this is almost close to term. We will deliver them if their STV analysis is less than 4.5 millisecond or absent end diastolic flow. Or absent end diastolic flow. However, the last set is this part. We will deliver by 36 to 36 plus 6 weeks if pulsatility index is more than 95th centile. All right. But when there will be reverse end diastolic flow is always dangerous. It means that heart is not coping well now, okay? Because the flow is getting reversed. So in this scenario, what you will do? In the early preterm labor, you may deliver them by 32 weeks, okay? Or you may deliver by 34 weeks if, this set of women, 29 to 31 plus 6 weeks. You may deliver if, the spontaneous repeated deceleration on CCTG is there, or if there is maternal indication. All right. So, middle cerebral artery or cerebral placental ratio, if it is less than 5th centile, should determine frequency of surveillance with umbilical artery Doppler and CCTG. They should not initiate delivery before 37 weeks. Anyhow, your the target is to take the woman at least up to 37 plus 6 days. In this set of women, the late, the FGR, what you were doing, you may deliver if there is spontaneous repeated decel on CCTG, maternal indication, STV is less than 4.5, or absent and reverse and diastolic flow. Like I said earlier, reverse and diastolic flow is an indication to deliver anytime in the early FGR, but absent and reverse is going to be indication to deliver in the late FGR as well. I hope it is not complicated. Clear, everyone? Clear, everyone? Good. It needs a lot of, the revision. However, at least you will have a fair idea after this session that how to read this guideline properly. Okay? And then when you will revise it with yourself, things will be easy. Then the delivery, important, right? We have managed, we have diagnosed, we have done everything. Then how to manage? If it is preterm birth, then the antenatal steroid should be given from 24 weeks to 36 weeks, 34 plus 6 weeks, ideally 48 hours before an anticipated birth, right? If there is no, the NICU, anyone who wants to leave can leave, okay? So because we have to finish this guideline, no problem. Ensure the neonatal team who is involved in the preterm birth is anticipated. It is important that the woman and the family has been counseled properly. Ensure that the neonatal team is involved. All right. Magnesium sulfate for the neuroprotection. So this is also one of the exam question. Magnesium sulfate for neuroprotection should be offered between 24 and 29 plus 6 weeks and considered up to 33 plus 6 weeks. Full stop. And when you are going to give them, if there is anticipated birth within 24 hours, or if a patient is admitted with the advanced labor, more than 4 centimeter. What it will do, it is going to be neuroprotective. It will reduce the risk of cerebral palsy. Exam question straight away. Offered between 24 to 29 plus 6 means we have to give it by any means, but we may consider it up to 33 plus 6 weeks. Mode of birth depend on if abnormal CCTG was there, ductus venosus alteration, umbilical artery was absent or reverse, it means this baby cannot take stress of normal vaginal delivery, right? So cesarean birth is recommended, full stop. Cesarean birth is recommended. But if the SGA fetus or late FGR with normal umbilical artery Doppler or with abnormal umbilical artery pulsatility index, but diastolic velocity is present, induction may be offered. If induction is offered, mechanical methods should be considered. Okay, mechanical methods mean Foley's induction. Early admission is mandatory. Okay, in all recent studies reporting outcome of the babies of SGA fetuses with reverse and absent has been cesarean birth, and therefore it is not possible to determine the likelihood of the adverse outcome because already baby is coming from hostile environment. So nobody can guarantee that after birth baby is going to be fine. All right. So the older series report shows intrapartum fetal heart rate deceleration. Postnatal investigation and counseling is important. If it was, we can send placenta for the histopathological examination if there is any recurrence of the FGR or SGA. Okay. If FGR was diagnosed prenatally or at birth to understand the underlying causes and guide the management. Women who have given birth to a growth-restricted infant should be offered an appointment with the postnatal counseling. Very important. Important to confirm the pathology and optimize the future pregnancy management and modify any risk factor. The British Society of Hematology recommends against testing of the hereditary thrombophilia, but acquired thrombophilia can be done. Okay, hereditary means any the factor V laden mutation or any other. Acquired mean APLA, SLE, we can do. A plan for the future pregnancies should be done. We should counsel her for smoking cessation, aspirin treatment, and it should be recorded in the notes and discussion with the woman. Future pregnancy plan should be given. because the modifiable risk factors should be done: lifestyle modification, smoking, BMI, medical condition optimization, and aspirin in the future pregnancies. So this was all about small for gestational age guideline. I hope it is somewhat clear. Any question, guys? Any question? Everybody was kind of the mute, or you can say that maybe absorbing the things. Anything which was not clear, anything which needs another the explanation from my side. I'm the here to answer any query. Brilliant. So we will upload this recording once it is done. Okay, meanwhile, if you guys have any question, or if you guys want me to do another session on any other guideline, because recently two guidelines have been the updated: twins and triplets nice guideline, and one more thing, hysteroscopy. Okay, the green top guideline. So I will be doing all these things time to time, with the the whenever I will get time. I will recurrent miscarriages. Okay, done. Okay, no problem. I'll do that. Okay, for recurrent miscarriages, we do have the green top guideline, as well as we do have a TOG article as well. So I will try to bring a combination of the both. So we will have another discussion. Not FGR, no, not all FGR or SGA at all. Okay, small for gestational age mean only the centile is less, but when it will be coupled with Doppler abnormality, it will be termed as FGR. Okay. Maternal medicine, maternal medicine itself is a whole spectrum of a huge module. Okay, so for complete maternal medicine, I think you will have to join my course. Okay, because it's fairly impossible to cover maternal medicine in one session. However, I can bring the some of the maternal medicine disorder in chunks, and we can discuss. Okay, for example, we can discuss multiple sclerosis, we can discuss asthma, we can discuss the hypertensive disorders, or maybe the any other disorder. So if you guys want any other special session by me, so please do write to me. Okay, on our groups, Facebook groups, and the WhatsApp group as well, Telegram. I'm available, I'm open. Okay, so you guys can the search my name, and you guys can send me suggestion, and I will try to to bring whatever is going to be good. VTE guidelines. Okay, I'll try to do. I'll try to do whatever I could, because I am myself am very occupied. Okay, because I am a part 3 examiner as well. I am doing part 3 sessions, part 2 sessions as well, MRCPI as well. So I will try to. Okay, because this SGA guideline, my candidates were pretty the upset on that. So I thought to summarize it and try to explain it with the best of my knowledge. I hope I was successful. So thank you so much, guys, for being attentive. So thank you so much. If you guys have any query, any question, you guys can write to me. All right, so I will see you inshallah some other time. Bye bye, Allah Hafiz, and good night.